Welcome back to the deep dive. Today, we're really getting into it, tackling some really common but potentially serious symptoms: chest discomfort, abdominal pain, and headache.
Yeah, these are incredibly frequent. I mean, almost everyone feels these at some point.
Yeah.
But the challenge, clinically speaking, is huge.
Yeah.
How do you reliably sort the minor stuff from a true emergency? It's a real test of skill.
Absolutely. And for this deep dive, you've provided some incredibly detailed medical sources. They really break down the approach, the biology, the specific conditions.
Mm.
So our mission today, using these texts, is to go deep, like really deep, cover everything the sources mention, aiming for that level of mastery you see in top professionals. No holding back.
Okay, let's jump in. Starting with acute chest discomfort, the sources right away, they hit this central problem. You've got a lot of people coming in with chest discomfort, but only a small fraction have something truly serious, life-threatening.
Right.
How do you find that small group reliably, quickly, without over-testing everyone else who's low risk? That's the balancing act.
Sounds like walking a tightrope, really.
It absolutely is. And the sources talk about how many hospitals use these critical pathways,
Right.
often in dedicated chest pain units.
Okay, what's the idea behind those pathways? What are they trying to achieve?
Well, it boils down to efficiency and safety. Goal one, rapid identification, quick triage, and getting treatment started fast for the high-risk stuff.
Yeah.
Think serious heart or lung conditions. The sources specifically call out STIMA, that's ST elevation myocardial infarction, a major heart attack.
Okay, speed for the urgent cases. Makes sense.
Goal two,
Yeah.
accurately figuring out who is low risk. Can they be safely watched, maybe get some non-invasive tests sooner, or even go home without a long admission?
Sorting things out efficiently.
Exactly. Which leads to goal three, resources, trying to safely cut costs. These systematic, accelerated diagnostic protocols, they aim to evaluate people efficiently, avoid unnecessary tests, shorten hospital stays.
And do they work?
The studies mentioned in the material, they show these pathways can decrease costs and evaluation times in the hospital, and crucially, with no detectable increase in bad outcomes. So yeah, it's a validation of being systematic.
That's impressive for the emergency setting. But what about, someone goes to their regular doctor with chest pain? How's that different?
Oh, it's a completely different ballgame.
Yeah.
Mostly because the pretest probability of it being an acute, life-threatening heart or lung issue is just much, much lower in the office.
Okay.
Chest pain is super common out there. The sources say lifetime prevalence is like 20–40%. But here's the kicker. Over a quarter of people who actually did have a heart attack had seen their primary care doc for related symptoms in the month before.
Wow. That really highlights the difficulty, doesn't it?
It absolutely does.
Mhm.
So because the immediate risk is lower in the office, the testing approach is less intense. You rely much more heavily on the fundamentals, a really detailed history, a thorough physical exam, and a resting ECG.
So you can't just apply those ED protocols directly.
Not really, no. Those decision aids built for the high-risk ED environment. They're less accurate, lower positive predictive value in the office setting. But there's a critical line the sources draw. If, in that outpatient setting, your clinical suspicion for acute coronary syndrome, unstable angina, or an MI gets high enough that you're even thinking about ordering a troponin test, a blood marker for heart damage,
Yeah.
then that patient needs to go to the ED for a full evaluation, period. That threshold is absolutely vital for safety.
Got it. If the suspicion hits that level, the ED resources are necessary. Okay, let's dig into some specific tools mentioned for chest discomfort beyond the basics. Non-stress echocardiography.
Right, so a non-stress echo, an ultrasound of the heart, isn't routine for all chest pain. The sources say it's needed when the diagnosis isn't clear. Maybe the ECG is confusing, symptoms won't stop, or the patient's blood pressure or heart rate is unstable, hemodynamically unstable.
And what critical things can it show you then?
It's good for looking at how the heart muscle is moving. Abnormal regional wall motion. That suggests possible ischemia, maybe damage from poor blood flow. It's also key for finding mechanical complications after a heart attack, or diagnosing pericardial tamponade, that dangerous fluid buildup around the heart.
Any limitations?
Yeah, it's not great for spotting aortic dissection, although sometimes you might see the tear, the intimal flap in the ascending aorta,
Right.
but it's not the go-to test for that.
Okay. How about cardiac magnetic resonance imaging, CMR?
CMR, the sources highlight this as an evolving and really versatile tool. It gives you detailed pictures of the heart's structure and function and the blood vessels in the chest. You can even use it with stress agents to look at blood flow, perfusion within the heart muscle itself.
And the sources mentioned using gadolinium contrast with it.
Yes, Gadolinium-enhanced CMR is powerful stuff. It can pick up heart attacks very early, map out the exact areas of damaged tissue, necrosis, and it's really good at showing different patterns of heart muscle disease, which helps you figure out why there's damage. Is it ischemic from a blocked artery? Or non-ischemic, maybe inflammation?
So it goes beyond just saying damage to hinting at the cause.
Exactly. But there's a practical limitation. CMR usually isn't the first choice for urgent evaluation of acute chest discomfort. It just takes longer and isn't always as readily available in an emergency compared to, say, a CT scan.
Where does it really shine then?
It's very useful for evaluating the heart structure in patients who have those elevated troponin levels, the heart damage markers, but where tests haven't shown clear coronary artery blockages. It helps look for other reasons for that enzyme leak.
And aortic dissection again.
Right, MRI is actually highly accurate for aortic dissection. But again, like with acute chest pain, CT or transesophageal echo are often more practical as the first test in an emergency, just because they're usually faster and easier to get done quickly. The sources also note that CMR for looking directly at coronary arteries is still kind of in its early stages.
Okay, that gives us a solid picture of chest discomfort. Let's shift gears to abdominal pain. The sources call this a major diagnostic challenge, where catastrophic events can start subtly.
Yeah, this is where clinical skill is really put to the test. The absolute core task, and the sources hammer this home, is telling the difference between conditions needing urgent intervention, often surgery, and those you can manage without operating.
And the foundation for making that call.
It always comes back to a meticulously executed, incredibly detailed history and physical examination. The sources are clear. This is critical for narrowing down the possibilities, focusing your thinking, and speeding up the whole evaluation.
What makes a history meticulous in this context?
It's about the details. The patient's age, exactly when and how the pain started, what it feels like, sharp, dull, cramping, burning, how long has it lasted, where is it exactly, does it radiate, and crucially, associated symptoms, nausea, vomiting, appetite changes, bowel habit changes. And for female patients, a detailed menstrual history is non-negotiable. Getting all that info up front is key for mastery.
Skipping those steps seems like a recipe for disaster.
It really is. The sources give a useful framework, sort of an etiologic classification to organize your thinking, broad categories of causes.
Like,
Is it inflammation of the peritoneum, the abdominal lining? Is it a blockage in a hollow organ like the bowel or bile duct? A vascular problem? Pain from the abdominal wall itself? Is it referred pain coming from somewhere else like the chest or spine?
right.
Or could it be metabolic, neurogenic, toxic, maybe even psychiatric? Thinking in these categories helps.
What usually brings people into the hospital with abdominal pain, according to the sources?
The most common reasons listed for admission are nonspecific abdominal pain, meaning you can't pin down an exact cause easily, then acute appendicitis, pain coming from the urinary system, and intestinal obstruction.
And the sources warn about some really crucial misconceptions, right? Things that can lead you down the wrong path.
Yes, these are so important. First, they say don't use acute or surgical abdomen as a diagnosis. It's misleading, implies surgery is needed without saying why. Also, while most acute abdominal pain does resolve on its own eventually, you can't assume that at the outset.
Okay, don't assume it'll just go away. What else?
This one's huge.
Yeah.
The severity of the pain does not reliably tell you how severe the underlying condition is. You can have terrible pain from something relatively minor and only mild pain from something potentially lethal. Absolutely. Similarly, whether someone says they're hungry, not a reliable sign. And here's the paradox. Someone who looks obviously terrible, rigid abdomen, clearly in distress, they might not actually need surgery, while someone with just mild pain might have something that needs urgent correction. That mild pain could be an early critical warning.
That insight alone feels vital for achieving mastery, paying close attention even to mild pain. Let's dive into the mechanisms. How does the pain actually happen, starting with inflammation of the parietal peritoneum, the lining?
Okay, this type of pain is typically steady, aching, and it's felt right over the inflamed areas well localized. Why? Because that parietal peritoneum has somatic nerves, like your skin, which give precise location info.
And what determines how bad it feels?
Two main things, according to the sources. The type and amount of whatever is irritating the peritoneum and how fast it gets there. Think about it. A little bit of sterile, acidic stomach juice leaking out. Much more painful than the same amount of contaminated but neutral feces. Pancreatic enzymes are more irritating than sterile bile, blood, or urine. Usually only mildly irritating unless it's a sudden, large leak. But the rate matters too. A sudden perforation is generally much more painful than a slow leak.
How does the patient act with this kind of pain? What do you see?
The classic finding is that any movement makes it worse. Coughing, shifting position, even a jolt like hitting a bump in the road. So patients tend to lie incredibly still, very quiet. That's a big contrast to someone with colicky pain who might be restless.
And you often see muscle rigidity.
Yes, often a tonic reflex spasm of the abdominal muscles right over the inflamed spot.
Yeah.
But this is critical. The intensity varies a lot. It depends on the person's nervous system, the location, maybe less rigidity if the inflammation is behind the bowel, like a retrocecal appendix, because other organs cushion it, and again, the rate of development. Okay, and here's another crucial point. In really sick, compromised patients, obtunded, frail, immunosuppressed, on steroids, maybe psychotic, you might see minimal or even no pain or spasm, even with a catastrophe inside. Also, slowly developing inflammation leads to less spasm. You absolutely cannot hang your hat solely on rigidity or its absence.
That's a really important nuance. Okay, switching mechanisms. Pain from obstruction of hollow viscera, like a blocked intestine or bile duct.
The classic description is intermittent colicky pain, that cramping that comes and goes. But the sources emphasize this significant stretching or distension of a hollow organ can also cause steady pain, maybe with just occasional cramping on top. So if the cramping isn't there, it absolutely does not rule out an obstruction. That's a potential pitfall.
And where is this pain usually felt?
It's generally not as precisely localized as parietal pain. It's often felt more towards the midline. Small bowel obstruction, typically poorly localized, maybe intermittent pain around the belly button or just above it. As the bowel stretches more over time, that colicky feeling might fade. If it's strangulating blood supply cut off, the pain might become more constant, maybe spread to the lower back due to pulling on the mesentery.
And the colon.
Colonic obstruction pain is usually less intense, felt lower down, below the umbilicus, and can radiate to the lower back too.
What about the biliary system, gallbladder, bile ducts? The source is corrected biliary colic.
Yeah, they make a point of saying that sudden distension causes steady pain, not really colic. Acute gallbladder trouble, usually upper right quadrant pain, RUQ, maybe radiating to the right back or shoulder blade, sometimes midline. Common bile duct distension, often felt in the epigastrium, upper middle abdomen, maybe radiating to the upper back. But if the duct dilates slowly, like from a tumor growing gradually, there might be no pain or just a mild ache.
And the pancreas and urinary tract.
Pancreatic duct pain is similar to bile duct pain, but the sources highlight a frequent feature. It's often worse when lying down and better when sitting up. That's a useful clue. Bladder obstruction. Usually dull, low-intensity pain above the pubic bone. Sometimes, in someone not fully alert, just restlessness might be the only sign. Acute ureter obstruction, though, like from a kidney stone, that's severe flank pain radiating down towards the groin or genitals on that side. The exact pattern can hint at where the blockage is.
That level of detail on pain patterns is incredible. What about vascular problems? Issues with blood vessels in the abdomen.
Right, another area with misconceptions. Yes, severe, sudden, diffuse pain can happen like a big clot blocking the main artery to the gut, the superior mesenteric artery, or an aneurysm about to rupture. But, and this is key, mesenteric artery occlusion often causes only mild, continuous, or cramping diffuse pain for maybe 2 or 3 days before the patient collapses or shows signs of peritonitis.
Why the delay in severe signs?
Because that early pain isn't from dead tissue yet. It's from the bowel working overtime, hyperperistalsis, trying to function despite the lack of blood flow. This leads to that classic critical sign. Continuous diffuse pain but minimal or no tenderness or rigidity on exam, especially in someone with risk factors for vascular disease. Pain out of proportion to physical findings. Recognizing that early is absolutely vital. An impending aortic aneurysm rupture can also cause pain building over days before the big event.
So again, mild pain, potentially signaling something very serious. What about pain from the abdominal wall itself?
That's usually constant and aching. It gets worse with movement using those muscles, standing for a long time, pressing on it. There might be associated muscle spasm. A specific, though rare example is erected sheath hematoma bleeding into the abdominal wall muscle, often in people on anticoagulants. It can feel like a mass. Differentiating it from intra-abdominal pain involves noting it doesn't relate to digestion or maybe finding similar muscle pain elsewhere.
Okay, we've got the lining, hollow organs, vessels, the wall, but pain can also be referred from other places, right?
Absolutely. This is a huge potential pitfall. Pain referred from the chest, the spine, even the genitals can feel like it's coming from the abdomen. There's a crucial rule emphasized in the sources. Always consider intrathoracic disease chest problems in anyone with abdominal pain. especially upper abdominal pain.
What chest issues commonly mimic abdominal pain?
The list includes heart attack, MI, pulmonary infarction, lung clot, pneumonia, pericarditis, inflammation around the heart, and esophageal problems. So you have to ask about chest symptoms, listen to the lungs carefully. A specific example given: diaphragmatic pleuritis, inflammation of the lung lining near the diaphragm, can cause upper abdominal pain, often RUQ, plus pain above the collarbone, supraclavicular pain. That pattern helps distinguish it from, say, gallbladder pain, which might refer under the shoulder blade, subscapular.
How do you sort it out if it's ambiguous?
Sometimes the only way, according to the sources, is careful observation over several hours, repeated questioning, repeated exams. See how things evolve.
Are there specific exam clues for referred chest pain?
Yes. The patient might be guarding or splinting that side of their chest more obviously than you'd expect just from abdominal pain. Also, the abdominal muscle spasm you feel might decrease when they breathe in, whereas true abdominal spasm usually persists throughout breathing. And palpating the area of referred pain in the abdomen often doesn't make it worse, might even feel better.
That's a great clinical pearl.
It is. And things can coexist, of course. Someone might have biliary pain triggering angina, or a heart attack causing abdominal symptoms. Pain can radiate to old problem areas, too.
What about referred pain from the spine?
That's typically worse with things like coughing, sneezing, straining things that increase pressure around the nerve roots. You often find hyperesthesia, increased skin sensitivity over the affected dermatomes.
And from the testes or seminal vesicles?
Usually a dull, aching, poorly localized abdominal discomfort. The key is that it's made worse by even slight pressure on the testes or during a rectal exam assessing the seminal vesicles.
Wow, so many non-abdominal causes. The sources also cover metabolic crises causing abdominal pain.
Yes, certain systemic metabolic conditions can mimic almost any intra-abdominal surgical problem. Sometimes the metabolic issue directly triggers something abdominal, like high lipids causing pancreatitis. The sources warn against rushing to surgery without recognizing the underlying metabolic driver.
Examples.
C1 esterase deficiency causing angioedema attacks can involve severe abdominal pain. Familial Mediterranean fever. Porphyria and lead colic can be tough, mimicking bowel obstruction due to intense hyperperistalsis. Uremia or diabetic ketoacidosis can cause non-specific shifting abdominal pain.
And a specific caution about diabetes.
Crucially, diabetic ketoacidosis can be triggered by an underlying problem like appendicitis or obstruction. So if the abdominal pain doesn't resolve quickly when the DKA is corrected, you must look for that underlying surgical cause. Don't just blame the diabetes. A dramatic example mentioned: black widow spider bites, causing intense abdominal and back rigidity. The back involvement is a clue.
The list keeps growing. Then there's the challenge in immunocompromised patients.
Extremely difficult. Their normal responses, inflammation, fever, pain, can be blunted or absent, so evaluation is tough.
What specific risks do they face?
They're prone to unusual infections causing abdominal pain, CMV, mycobacteria, fungi, protozoa. These can hit any organ, cause hidden perforations. Think splenic abscesses with LUQ pain. A calculus cholecystitis is more common, often linked to cryptosporidiosis or CMV. Neutropenic enterocolitis, typhlitis, in chemo patients. Acute graft versus host disease after transplant.
So you need a high index of suspicion for unusual things and subtle signs.
Absolutely. Meticulous follow-up, serial exams are key to catching things like perforations early.
Let's briefly touch on neurogenic causes.
Pain from nerve issues. One type is causalgic pain. Burning in a nerve's distribution triggered by normally non-painful things like touch, often present at rest. Crucially, no abdominal rigidity or distension not related to food. Another type is from spinal nerve roots, sudden, sharp, lancinating pain caused by shingles, arthritis, tumors, disc herniation, diabetes, syphilis. Again, no relation to food or distension. Muscle spasms, if present, might feel better with palpation. Pain is worse with spinal movement, limited to dermatomes, often with hyperesthesia.
And functional disorders like IBS.
These are common, diagnosed based on clinical criteria after ruling out structural problems. Irritable bowel syndrome involves abdominal pain linked to changes in bowel habits, often triggered by stress. Pain varies, nausea, vomiting are rare, and importantly, no localized tenderness or rigidity.
Okay, we've covered a massive amount on causes and mechanisms. Let's synthesize this into the overall approach to the patient with abdominal pain as outlined in the sources.
Right. A key starting point, maybe surprisingly, is that very few conditions need such urgent surgery that you abandon an orderly approach. The one major exception: massive intra-abdominal bleeding, like a ruptured aneurysm.
For that, it's straight to the OR.
Essentially, yes. Immediate transfer, rapid assessment, IV access, then surgery only minutes for the initial steps. No delays for extensive imaging. This doesn't apply to bleeding inside the GI tract, though. That's managed differently.
But for almost everything else, a methodical approach is best.
Absolutely. The detailed history is paramount. Even if it's time-consuming, it's the most crucial step for decision-making, often allowing a likely diagnosis before tests.
Does acute versus chronic pain change the history focus?
Generally, acute pain diagnoses are more readily established. Chronic pain is often trickier, and IBS is a very common cause to consider after ruling out other issues.
We talked about location clues, RUQ, RLQ, etc.
Yes, using location to generate a differential diagnosis is helpful. RUQ, gallbladder, liver, RLQ, appendix, LOQ, diverticulitis, and so on.
But location isn't everything.
No. The sources state emphatically that the chronological sequence of events, the story of how symptoms developed, is often more important than just where the pain is. When did the pain start relative to vomiting? Did fever come first? That timeline is critical, and always think about extra abdominal causes.
What about giving pain medication? Does it mask the diagnosis?
The sources argue against withholding necessary pain relief. They state that adequate analgesia is unlikely to truly hide the signs of a condition needing surgery. Treat the suffering, you can still evaluate effectively.
And menstrual history in women absolutely essential.
Non-negotiable. For considering GYN causes, pregnancy effects, interpreting labs.
Moving to the physical exam, what are the guiding principles besides just poking around?
Start with just looking. Facies, position in bed still or restless. Breathing pattern, these give clues. Then, gentleness and thoroughness are key. A rough exam induces guarding, ruins it for others.
How about checking for rebound tenderness?
The sources strongly advise against the sudden hand withdrawal method. They call it cruel and unnecessary. Gentle percussion, or asking the patient to cough, elicits the same information, true rebound, if present, without startling them or causing protective spasm.
So gentle palpation allows you to feel more.
Exactly. Take your time. Avoid causing voluntary guarding that hides a mass or enlarged organ. And remember, minimal signs, if consistent with the history, can be extremely significant, especially in compromised patients.
And pelvic and rectal exams, still crucial.
Mandatory. Every single patient. Pelvic peritonitis might have few abdominal signs. Tenderness found only on these exams can point directly to surgical conditions like a low-lying perforated appendix, diverticulitis, twisted cyst, ectopic pregnancy. Can skip them.
What about listening for bowel sounds? Still important.
Surprisingly, the sources say it's one of the least revealing parts of the exam. Catastrophes can happen with normal sounds. A silent abdomen is rare, usually only in severe chemical peritonitis. Don't rely heavily on bowel sounds.
That's counterintuitive for many. Okay, lab tests.
Useful, but rarely diagnostic on their own. Leukocytosis, high white count, should never be the sole reason for surgery. High counts occur in many non-surgical conditions too. And a normal white count is common even with perforations.
So normal WBC doesn't rule out badness.
Precisely. Anemia plus the history might be more helpful. Urinalysis checks hydration, renal issues, UTI, BUN, glucose, liver tests. Bilirubin can add pieces depending on suspicion.
And serum amylase for pancreatitis?
Again, caution needed. Many things besides pancreatitis raise amylase, perforated ulcer, bowel obstruction, cholecystitis. Elevated amylase doesn't confirm pancreatitis or rule out surgery. Just one data point.
Labs are supportive, not definitive. What about imaging?
Plain x-rays. Limited value now for non-traumatic pain, often unnecessary if clinical signs are strong. Low-dose CT is generally preferred when the diagnosis or need for intervention isn't clear from history and exam.
Contrast studies. Barium.
Upper GI contrast is rare now. Only specific uses like partial obstruction. Avoid barium if you suspect colonic obstruction. A contrast enema can be useful for suspected colonic obstruction if there's no perforation.
Other imaging modalities.
Peritoneal lavage is mostly historical outside trauma. Ultrasound is great for gallbladder, pancreas, ovaries, tubal pregnancy. Laparoscopy using a scope is excellent for pelvic issues. Cysts, ectopic, appendicitis. Big plus, you can often treat what you find right then and there.
Diagnostic and therapeutic.
Exactly. HID scans help differentiate gallbladder issues from pancreatitis sometimes. And CT is fantastic for seeing organ enlargement, inflammation, thickened bowel walls, inflammatory stranding around the appendix, or colon in appendicitis or diverticulitis.
That covers a lot of diagnostic ground. What if, after all that, the diagnosis is still murky?
The sources acknowledge this happens. Sometimes, even with everything, it's unclear. If clinical suspicion for something serious remains high, surgery might still be the right call based on judgment alone. But if it's questionable, the best approach is often watchful waiting. That means repeated questioning and critically repeated physical exams over hours. Things often become clearer with time and reassessment. It requires patience and ongoing clinical thought.
Really emphasizes that clinical skill and observation are paramount, not just ordering tests. The sources credit William Silen showing these principles endure.
They absolutely do. This is the foundation of expert clinical reasoning in these situations.
Okay, let's pivot to our final topic. Headache. Another incredibly common reason for seeking care and a major cause of disability globally.
Absolutely. And like the others, diagnosis and management hinge on a careful clinical approach, plus understanding the nervous system pathways involved. The International Headache Society classification provides the main framework, dividing headaches into two big categories,
Which are
primary headaches and secondary headaches. Primary means the headache is the disorder tension type, migraine, cluster headache, etc. These are super common, often disabling, but the headache itself is the problem.
So you treat the headache condition.
Right. Secondary headaches are different. They're a symptom of something else, an underlying disorder. Mild secondary headache, like with a cold, common, usually no big deal. But you have to be vigilant for the uncommon but life-threatening secondary causes. Systemic infection, head injury, vascular issues like subarachnoid hemorrhage, bleeding around the brain, brain tumors.
The prevalence numbers cited in the sources really show the difference.
It's stark. Lifetime prevalence for tension-type headache, around 69%. Migraine, 16%. Now compare that to the frequency of causes of secondary headache among headache patients. Things like subarachnoid hemorrhage or brain tumor are each listed as causing less than 1% of all headaches presenting for care. So serious causes are rare, but you cannot miss them. That's the challenge the mastery needed.
Searching for that needle in the haystack. So why do headaches happen? What's the underlying anatomy and physiology?
Well, pain generally comes from stimulating nociceptors, pain receptors, due to injury or stretch, or the pain pathways themselves, peripheral or central, can be damaged or misfire. Headache can involve either or both.
What parts of the head actually feel pain? It's not the brain tissue itself, is it?
Correct. That's a key point from the sources. Much of the brain parenchyma is not pain sensitive. What is sensitive? The scalp, arteries in the meninges, brain lining, the large dural sinuses, venous channels, the falx cerebri, dural fold, and the parts of the large arteries on the brain surface closest to the brainstem.
And what parts don't feel pain?
The lining of the ventricles, ependyma, the choroid plexus that makes spinal fluid, the surface veins, pile veins, and most of the brain tissue. This explains why, say, a tumor might grow quite large before causing headache, usually by distorting or pressing on those nearby pain-sensitive structures or raising overall pressure.
Fascinating. So for primary headaches like migraine, what structures are the main players?
The sources point strongly to the large intracranial blood vessels and the dura mater, plus the peripheral terminals of the trigeminal nerve that supply sensation to these structures.
The trigeminal nerve again. Big role in head pain.
Huge. Specifically, the lower part of its nucleus in the brainstem, the trigeminocervical complex. It extends down into the upper cervical spinal cord, getting input from C1 and C2 nerve roots. This convergence is why head pain can be felt in the neck, and neck problems can cause headache.
And then higher brain centers process it.
Exactly. Areas like the thalamus and cortex are involved in perception. But it's not just raw input. Pain modulatory systems in the hypothalamus and brainstem shape the experience, influencing the signals coming from the trigeminal system. These modulatory areas also connect to regions controlling autonomic functions, which helps explain associated symptoms like nausea, light sound sensitivity common in migraine.
Understanding those pathways really deepens the appreciation for why headaches present the way they do.
It really does. It moves you towards understanding the complex neurobiology behind these common, often debilitating conditions.
Well, we have covered an immense amount of ground today on acute chest discomfort, abdominal pain, and headache, really extracting the deep details from the source material you shared.
Yeah, it's clear how these common symptoms open doors to incredibly complex physiology and diagnostic reasoning. Mastery here isn't just knowing lists of causes, it's understanding pain mechanisms, subtle history and exam clues, and the smart use and limitations of tests.
Absolutely. And that was the goal of this deep dive. Pull out all that crucial detail, those core concepts from the texts, to really move towards that elite professional level of understanding and application. It's about integrating everything.
Thinking like that expert clinician means, fundamentally, trusting your history and exam skills even when tests are ambiguous, keeping a broad differential, but systematically working to exclude the dangerous possibilities first.
So, given how often these seemingly simple symptoms can hide such complex problems and the sheer depth required to truly understand them, what does this deep dive really tell you about the fundamental value of careful, systematic clinical assessment, perhaps even more so than just reaching for the next test?